Staying on topic is going to be Leonard Baidoo. Leonard started his faculty career at the University of Pittsburgh, was recruited to Northwestern 2 years ago to lead our program, and he's going to talk about stepping up therapy. So step up,
Leonard. I'd like to thank the organizers for inviting me here, and Scott, thank you for bringing this show on the road to my city, my new city now. Welcome, everybody. Like you all said, we're going to, another good advice to everybody is don't debate with the organizer, right? The chances are that you get the wrong one. I'm going to talk about step up as opposed to top down. And like Dr. Hanor said earlier on, in IBD, there's always a pendulum that swings both ways. Over the last couple of years, everybody has been talking about top down. Maybe after today, we might start moving the pendulum in the other direction after what I have to say. Right, so I just started gently by giving you a definition of what we mean by step up. And I think this refers to a sequential treatment strategy that often uses effective but potentially less toxic treatment strategies such as salicylate, some budesonide, with escalation to potentially more effective but probably more toxic treatment. So you have to consider this in effect. This strategy usually avoids over-treating patients, unnecessarily exposing them to risk of developing the drug adverse effects, and especially in subgroups of patients who do not do well with this paradigm. The reason why this is important is this is a topic that has been going on for years. And if you see down at the bottom there, this thing was printed in 2004, and we are in 2017, and we are still talking about it. Right. So if you look on the left side, the superior strategy, which is the step up, you most probably will start with 5-ASAs, go to steroids, azathioprine, and anti-TNFs and other biologics if necessary, and Scott's is the step down. The reason why a lot of people may have been talking about step down is because a majority of the people who talk come from tertiary teaching hospitals. They see the worst of the worst kind of patients, and they do not talk in terms of the practical things that the general gastroenterologist will see, the sort of patients that will be, they will have to treat. And I'm going to tell you why I think top down may not be ideal for everybody. Because some of the things we have to consider, everybody talks about it will alter the natural history of the disease long term. Does it maybe just delay the onset of these complications? Will this approach be totally safe, knowing all the complications associated with these drugs? There are very few people who have very aggressive course of disease that may benefit from top down. I give that to you. But the natural history of the disease is always very difficult to predict. The patient comes to your office, like Dr. Hanor said, is the activity you are seeing at that time. There is no way you can tell the severity of the disease when you don't know a lot more about the patient. The current tools that are available to us now do not adequately identify those patients in advance, so we'll all jump to doing top down. There are no really objective ways of determining it, like Dr. Hanor said, and finding out which patients will respond to which medications without side effects. Many people are treated unnecessarily, I think, with potentially toxic and, in this time, expensive medications that they do not need. Some may argue that step-down therapy leads to higher rates of maybe complications. Could this be not because of the drug, but because of us doctors offering suboptimal treatment? Maybe if we treated our patient more effectively, that will not be an issue. And then when you talk about top down, when do you start coming down? Are you talking more about step and stay forever? Or when do you decide that you can come down from the top where you are? Those are some of the things that we come. And when we start treating our patients as they get better, the pharmacokinetics improve. And in those circumstances, sometimes they do not need all those medications. This is a thing that everybody has shown. And sometimes we look at it and say, this makes you feel like your patient has to earn the right to go to the next level. Right, so you have to go through the immunosalicylates. If they are not doing well, then you go to the levels as it were. The patient has to earn it. That is putting the onus on the drugs. But the patient, the problem must be us as doctors, our fault. So there's another way of looking at it, more like a step up way of looking at these drugs. And so you do not necessarily have to fail one drug totally before you go to the next. It's you, the doctor, who assesses the patient and decides how well you want to treat the patient. So I have this other way of looking at it, low intensity versus moderate intensity versus severe intensity. So if you have a patient that you assess in your clinic and you see they have low intensity type disease that I'm describing, what's the point of putting them on the biologic? You have no way of knowing how the patient is going to fare in future. There are many patients that we have seen that somebody comes to you after 20 years of disease and all they have been on is 5 ASAs and they're doing fine. If his doctor had seen him 10 years ago, he might be on a biologic. He may be doing fine, but at what cost? So everybody has shown this diagram that shows that over time, disease gets worse. My argument is that if we start treating these patients very early, they will not have to get to the stage where they start to develop strictures. So that is why I say it is not so much the drug as maybe us not doing the right thing at the appropriate time, which is early. That may be the problem. Everybody has seen this, and based on this, the more we treat them early and appropriately in the inflammatory stage, they are most likely not to get to the stage where we have to worry about strictures and perforations. So this is a very old slide that shows that, shows that when you see patients for the first time, the chances are that you only have about 20% of them who will have mild disease, but how many of them will have severe disease? Less than 10%. Right? Most of the majority of our patients, if you use the criteria that is listed on the right there, 4 stools per day or more than 6 stools per day, that tells you that a majority of our patients, which is the majority of the average gastroenterologist patient, will be in the moderate to mild disease range. If you follow these patients for a year, 50% of them will not have any symptoms. 30% or so will have low activity, and the high activity, high to moderate activity, will be only about 20%. So a majority of our patients do not need to be treated aggressively or top down in any fashion. You can start low if you do the right thing. To make it even more obvious, let's talk about some of the severity of using the sort of drugs I am talking about. The mesalamines, the 5-ASAs, and maybe the immunomodulators. Mesalamines is a low incidence of any adverse effects. Some people might get a bit of diarrhea, headaches. Few people at the start get abdominal pain. The things that we all worry about is nephrotoxicity, so we'll do the blood levels and find out, and there's rarely the occasional patient on azothioprine who might get pancreatitis. But we can pick up these very easily because the patient will get pain that they can't stay at home for. People talk about the possibility of getting lymphomas in azothioprines. I always put it this way. If you have a patient with IBD, that the disease will progress is a certainty if you don't do anything about it. But that they will develop a side effect to a drug is a probability. So do you want to deal with a certainty or do you want to deal with a probability? Right? So most people will most probably like to deal with a certainty. So if you have to use these drugs, although it is rare, you can always explain to your patients that it's possible, but it is rare. So there is no reason why you should not use these medications if you use it appropriately. So now let's compare it to some of the drugs. I use anti-TNF as an example. Everybody knows the side effects that nobody wants to hear about. Infections and malignancy, nobody wants to talk about it. There's a black box warning about hepatosplenic T-cell lymphoma that Dr. Hanwha spoke about. It may be rare, but almost all the patients who have it die. It's always a fatal disease. Would you want to be the doctor whose patient died because you put them on a drug? There's only been a few patients though, but they all have died. So, would you want to be that doctor, Scott? Okay. You have to do our usual test of checking for hepatitis B, recurring cancer. If you get skin cancer with these, it's most probably it's going to be a melanoma. It's not going to be a non-melanoma skin cancer like you're most likely to see from an immunomodulator. Some people may talk about autoimmunity with lupus-like reactions and demyelinating disorders that can affect people, and a lot of these may be irreversible. So considering these side effects, don't you think your patients will want you to use things that will not affect them badly? So I think the treatment paradigm should change, and everybody has said it in various ways or the other. The old treatment methods, we just treated symptoms. Now I think we should look at treating our patient looking for more objective markers of inflammation. People have talked about this in various ways. I think we should start looking for objective markers like CRP reduction, endoscopic mucosal healing, and radiological forms like using CT enterographies or MRIs. This is the way we should be treating our patient. It is not the problem of the drug, it's the problem of us as doctors not treating the patient sometimes appropriately. Everybody talks about mucosal healing. Granted, if mucosal healing is achieved, it will help to prevent disease progression. It will prevent complications and maybe the development of dysplasia, which we all worry about. And in acute disease, you always will see mucosal disease because it's easy to see. You scope the patient and you see that they have a mucosal disease. The problem, I believe, has been in maintenance. That is where we fail our patients sometimes. For maintenance, I think we should start developing the concept of treating to target, right? And if you adopt that concept, we are able to achieve our patients' growth, and it doesn't have to be just one drug, right? The concept of treating to target is not new to us in medicine. Diabetics treat their HbA1c to less than 6, and they believe that prolongs life. LDH cholesterol for the cardiologist, 70, lowers the incidence of cardiac events and strokes for blood pressure of 120/80. So treating to target is not a new concept. Most of us are beginning to accept it in IBD as well. So what is treating to target? I like to call it tight control. It is, if you treat persistent inflammation is what leads to tissue damage. So the concept of treating to targets rests on treating residual inflammation in patients who may be in clinical remission to prevent tissue deconditioning. So the problem has been that the patient comes to see us, he's fine. We assume he's okay. No, if we start treating to target, we'll be able to avoid patients getting these problems. So this is the concept of treating to target. You see your patient at baseline, right? You decide that, yes, this patient has ulcerative colitis. And like I said, most of 2/3 of your patient will be mild to moderate disease. Let's say ulcerative colitis. You can start by putting them on 5-ASA, but you decide with the patient ahead of time. You struck a deal, a contract that, look, I'm going to start treating you this way. In 6 months, I'm going to check. If you haven't improved by the objective measures that I'm telling you, which includes decreased CRP, nothing to show on your endoscopy or your imaging, I'll advance your treatment. So you set a target, say 6 months. So even though I started with 5-ASA, let's say I put you on 2.4 grams of Lialda. In 6 months, when I check you and those things haven't been achieved, I will increase your medication. I'm stepping up, but I'm not going all the way up because it might not be necessary. I might be able to improve your disease like I will do for most of the 60 to 65% of patients. There'll be no, so if it is not working right, you go back and evaluate until you get to the stage where your patient is avoiding long-term injury by showing objective signs of that you are treating them to the target, and the target being mucosal healing. Nobody can argue about the benefits of mucosal healing. And if you do the targets that you're looking for, these are the objectives that I am looking for. And some people have talked about deep remission, and sometimes that might be achieved. The deep remission for most of us is defined as A patient with no symptoms for 12 to 18 months, CRP, SED rate or calprotectin normal, nothing to show on your imaging or endoscopic healing. Who will challenge that if you have a patient in this state, you have to go up. If the patient is doing well on a lower level of medication, if you use the right strategy, the patient will hopefully be fine. This is an old study that shows that the chances of getting a resection in Crohn's disease or colectomy is reduced if at the end of the first year you have total mucosal healing, right? So it is early in the disease, as Scott suggested. You don't have to jump to everybody. You just have to be forceful, treat your patients with the appropriate level of medication, and follow them closely. The important thing is monitoring. If you monitor your patients closely, hopefully you won't get to this state. This is something everybody has talked about. When you see a patient, you have to decide which diseases are likely to be severe or not severe. And for most of our patients, they will not be like this in general practice. Maybe in the tertiary centers, these are the typical patients we see, but then you might see patients who smoke, have had prior surgeries. Those patients might not be the best to follow the step-up therapy like I'm talking about. These are, if you see somebody with a UC with deep ulcers, has been hospitalized at diagnosis, these are patients who are, to all intents, fairly severe and might not benefit from the step-up attitude. This is a study everybody refers to. You've seen it here about 3 or 4 times today. And it was a top-up and a top-down. There are many problems related to this study, and I believe Scott pointed some of these out. But the primary core endpoints were at 6 and 12 months were no CDI of less than 150, no steroids, no surgery. At about 8 to 12 months, there was a slight difference. But when they followed them out to actually 78 or 104 weeks, they started to come together. Does this suggest what I was saying, that maybe we just delay the onset of problems long term? And that maybe if we do the right things and we do it actively and scientifically, we might be able to get our patients there without having to jump everybody up to a top-down strategy. So this is something that I picked up from somewhere, put together. So when you see a patient with mild disease, there's no reason why you can't go down the ladder from 5-ASAs, budesonide, to corticosteroids, immunosuppressants, and if and only when these are not doing well, would you start to resort to biologics. And like I said, for a majority of our patients, we can get by with this, right? It's not the patients that Scott sees in his little clinic in Seattle who are all like this, right? So Miguel is not here, but he did talk about patients who have had resections, and that is, in my mind, a patient that you have put to the start of their disease, because you have got rid of the bad disease. So you are starting them out from like day 0, because sometimes we see patients who have had diseases for years, right? So the chance we get to do something good about them is when they have had surgery, right? So we always decide before we send our patients to surgery whether this is a severe patient, a mild patient, or a patient that we have to be aggressive with. And if we think that everybody must be on top-down therapy, why aren't we putting all our patients on biologics as soon after we finish the surgery? Because we would have brought them off, got rid of all the bad disease. And so that will be the opportune time to put everybody on a biologic if we thought that was the appropriate way of treating our patients. But based on the data that we have now, we all know that you have patients who can be divided, this is Miguel's slide that he showed, who can be divided into low, moderate, or high risks. And most of the patients will fall into the category on the left side. So you do not necessarily have to start treating them straight away with biologics. There are some of these that will go to immunomodulators. Granted, nobody uses 5-ASAs for this sort of patient, but the concept is that if you have got to the state where you've brought the patient to the beginning again, would this not have been the ideal state to put everybody on a biologic if we thought that was the way to go? So I'm giving you another evidence that we always have to do the best thing for our patients by following them in the right possible way. So what are some of the benefits of using Step Up? The patients attain remission with less toxic therapy. Potentially more toxic therapies are reserved for very severe patients or refractory disease, and we minimize the risk of adverse events. And if a lot of these drugs are not terribly expensive, so we'll save money. Our insurance colleagues will be very happy. Continuing along those lines, the concept of a patient earning the need to go to the next should be debunked. You have to treat the patient using a concept of treating to target, your target being mucosal healing. And if you do that, you'll be able to treat your patients without jumping to a biologic for everybody right from the outset. This gives you a chance to assess your patient's disease and use the appropriate therapy, and hopefully there will be no destruction. So what are the benefits of this step-up approach? I say you get to assess the risk and choose the appropriate level of treatment. And something I tell my patients, if you see a fly in your house in the summer, you can roll a newspaper up and whack it. You will kill it. If you're a good shot, you will shoot it. But the bullet might ricochet and hit your wife's leg. If you have connections, you can use a grenade. You blow it up, right? But you won't have a house afterwards. So in all these three scenarios, you will kill the fly, right? But you are wanting to use the appropriate level of medication to treat the appropriate level of disease that you have. So you induce and maintain remission with mucosal healing concept, and mucosal healing, like we all agree now, will lead to prevention of disease, and you can optimize surgical outcomes at the time where you come in. Like I said, it's going to be a relatively cheaper way of doing it. So the thing I want Scott to learn today is that you have to match the aggressiveness of your treatment with the likely aggressiveness of the disease. So, ladies and gentlemen, I'd like to ask you this question. This is a top-down car sitting on the top of a hill. Would you like to drive this down, not knowing the nature of the brakes? Or would you like to walk up confidently up the hill, stepping up? Thank you very much.